Welcome to our webinar, Digital Precision in Oncology, Unveiling the Digital RANO Tool. I'm Orlando Marin, your host of today's session. We are here to explore a groundbreaking development in neuro-oncology, the Digital RANO Assessment Tool. This tool promises to simplify brain tumor assessment with its precision and collaborative approach. Leading our discussion is Dr. Gerry Thompson from the University of Edinburgh, a renowned expert in radiology and neuroradiology. Let's dive right in and learn more about this innovative tool. Please welcome Dr. Thompson.
Thanks, Orlando, and welcome everybody. Hopefully you'll be excited as I am to find out about this new approach to collaborative RANO assessment for clinical trials, and also some of the follow-on and the power that unleashes in terms of making more of the data that we can acquire. So I'm just going to share my screen, and we can start the presentation. You seeing that okay, Orlando?
Yeah, all good.
Just go to laser pointer. So as I say, I'm Gerry Thompson, a senior clinical lecturer and academic neuroradiologist in Edinburgh. And what I'm going to talk about today is a bit of context to the Tessa Jowell brain cancer mission and one of the clinical trials platforms that's been funded as part of that, called the Tessa Jowell Brain Matrix. About the QMENTA cloud platform and the online RANO tool. So I'm going to assume some knowledge of RANO and trial endpoints. I'm not going to go into too much detail there, although happy to answer questions at the end. Then talk a bit about the platform and the biomarker marketplace, and I'll pay some attention to some radiotherapy related things, to some data science and integrity, and some semi-automated segmentation processes. And then we'll look about the additional response assessment potential of the tool, and why having this online tool has benefits over locally provided RANO assessments. And that will include things like RANO Resect, radiomics, and human-in-the-loop decision support, and touching on the QMENTA neuro data services and how that can combine the opportunities from platforms like Brain Matrix. And then we'll have a look at some opportunities at the end and a summary before we have a Q&A. So the Tessa Jowell Brain Cancer Mission, well worth Googling this and looking through the site at your leisure. Tessa Jowell, a very senior UK politician who died, unfortunately, of glioblastoma, and was instrumental in raising the profile of brain cancers and brain tumours in the UK, and has a foundation set up in her name and a brain cancer mission that has a lot of different aspects to it. But today, what I'm going to talk most about is Tessa Jowell Brain Matrix and how that fits in with the QMENTA RANO tool that we developed to help run it. So there are lots of stakeholders involved, as you can imagine. From the University of Edinburgh, this was heavily funded by the Brain Tumour Charity, a UK-based charitable organisation, and it has also some support from Genomics England. So the basic premise of this was around the difficulty, particularly that we had in the UK, of doing multi-centre clinical trials because of all the different imaging approaches and a lack of communication between centres. So the Brain Tumour Charity gave £2.8 million, so over $3 million or euros, with some in-kind match funding for the genomic and molecular aspects to fund this trial platform to really make it easier to set up and do clinical trials in brain tumours. So 10 centres with 3 strands, an imaging hub, a molecular hub, and a clinical hub. And the imaging hub basically wanted to bring in the imaging, centralise it, provide a web-based RANO assessment back to the various centres that were part of the trial. Again, tissue going to the University of Oxford molecular hub with whole genome sequencing, and this molecular tumour board providing feedback back to the trial. And then the Birmingham Centre taking care of all the clinical data and associated patient-reported outcomes. And the plan was to have about 100 patients per centre, with on average 5 or 6 time points per patients for glioma. With that, also the Tessa Jowell Centres of Excellence. So on the left here, we have a map of, these are the neuroscience centres in the United Kingdom. all but one of the centres that we've taking part in Matrix is one of these TESA adult centres of excellence. So these have applied through quite a strict process to become part of the network. So they have to show excellence in clinical care and research. We now are expanding to 15 Matrix centres. So the green ones are the centres that are already active. The orange ones are the centres that are coming online. And actually, of those 15 centres, they will cover approximately 40 million people in the UK out of a total population of 67 million. So covering more than half in this multi-centre trial platform. So what we did, how we selected how we were going to centralise and organise this data was quite important. And again, you can visit the QMENTA website. I won't go into too many details here, but QMENTA really provided an excellent one-stop shop, if you like, to put different clinical and imaging data with a smart uploader with real-time protocol adherence and de-identification that could be used both for human central review, adjudication, test, retest, but also opened the door to any AI or machine learning imaging biomarkers, and crucially for the imaging management system to allow feedback through APIs to other systems so that the data could be retrieved later. And it's fully audited and complies with all major jurisdictional requirements in terms of regulatory, and it's flexible and customizable, and those are two really important words for why we chose the system. And the smart uploader was really helpful in terms of how can we reduce the friction or the barrier to entry to allow individual sites to put their imaging data up onto the platform with as little fuss as possible, using that as the imaging hub. And I won't go through all of these, but again, you can browse the QMENTA website, but a lot of these things are important aspects of how the platform can be constructed and maintained, with particular things with compliance, auto de-identification, so that we don't inadvertently end up with identifiable data on the system, because privacy is obviously a key concern. Flexibility, that you can capture not just the imaging but associated clinical data that go with it. And the sort of the security and the access control and interoperability with different databases. For us, it would be the molecular database in Oxford and the clinical database in Birmingham. So let's move on to the actual RANO tool itself. And really what we're talking about in this instance is the modified RANO approach, which was from 2017, the original one being from a few years earlier, and RANO version 2 just released, but hopefully you'll see the flexibility in here. So this is the paper that provided the outline for the RANO assessment. And as a brief overview, this is just an example of the kind of graphic you'll see in a site manual for people that are doing assessments. You want to choose some enhancing lesions on a brain MRI, measure the diameters of them, classify them as target or non-target lesions, and then this is the kind of thing that you'll get: a caliper maximum dimension with the perpendicular, and all that happens is these are multiplied, so you get the products and then they're added, so it's the sum of the products of the perpendicular diameters, and that metric, that reductive metric, is used to determine if the patient's disease is improving, stable, or they have progressive disease. And there's quite a complex rubric in the modified RANO from 2017 to account for the fact that enhancement doesn't always mean active disease. And this is one of the reasons why having a digital tool is quite useful, because instead of someone locally inputting numbers that are on a paper bit of assessment filled in by a radiologist, then converting that and following this rubric to try and decide what the outcome was, this is all taken care of. They add in the relevant clinical data on imaging upload. The radiologist then does the assessment online, and in the background, the outcome of the RANO assessment is calculated. And you can see that for both newly diagnosed and recurrent GBM, it's fairly kind of complex rubrics. I will just draw your attention to this planar bidimensional approach that I showed you, which is the commonest way to do RANO. It is actually supplemented. There are options for a volumetric component, which I'll demonstrate later. And again, you can see there are lots of different outputs, and it can often be quite complex to work through this and decide what's happened, so automating this is often very useful. So the uploading process we wanted to be as slick as possible and easy as possible. So what we decided with was this once window drag and drop approach where you can, as long as you've got your scans identified and downloaded from the PACS system, you just need the participant ID, the site that you're uploading, and the date of scan. Now, these things like the treatment line and whether the patient is doing well clinically or not, and the corticosteroid dose, they are things that were always acquired or always recorded as part of paper RANO assessments. You just have to ensure that they're available at the time of imaging upload. But these, this is standard RANO assessments. Another benefit that the tool did offer is that the corticosteroid dose would automatically be converted if the person wasn't on dexamethasone, which is uncommon, but in some trials it did cause problems and deviations if the wrong type of steroid dose was used. And the way that this is based in terms of imaging events is that we can go all the way from neuronavigation software screen grabs for doing radiogenomics on the actual location of the biopsy. We can have radiotherapy plans that I'll show later. And then we can classify each of the imaging events. And these are the ones that are used for the RANO assessment. So MRI 01 onwards. And this is just a modification of the accepted RANO time points, but it gives very granular data as to when the data are acquired as part of the trial platform. So the RANO assessment itself, so I've got a quick video here just to avoid any gremlins of, let's just, hopefully we can, I'll just let this run. The first step after selecting the correct contrast enhanced imaging is to determine if there is any enhancing disease and if there are measurable lesions. Recall that measurable lesions for RANO would be more than 10 by 10 millimeters in plane, with appearance on 2 contiguous 5 millimeter slices on this imaging. Let's go ahead and define our lesions. So target lesion 1. You can see that the perpendicular component to the caliper is forced perpendicular, which helps with maintaining consistency. Let's add the second lesion. Here the caliper is a different colour, and again forced perpendicular. And you can jump between the lesions simply by clicking on the relevant label. So this bit should be familiar to anyone that has used paper RANO forms. So lesion 1 is a right frontal lobe lesion. Now this is baseline. It persists from surgery. Lesion 2, right frontal lesion. Save that. We don't need to add in any additional comments here. Let's save the editing. Go to the next step. So the next step is, are there any comorbid events that are evident in imaging, such as, you can see from this list, hydrocephalus, stroke, hemorrhage, infection, demyelination, anything that might indicate an alternative cause for clinical deterioration that isn't related to the tumour. And we can look at other sequences. This web viewer would be familiar to anyone who's used PACS. So there are no alternative causes, so let's submit that. Okay. So that was just an example there. That video just showed the process of what the tool looks like and how quickly you can undertake a RANO assessment as a radiologist. And myself and all of the colleagues that I've spoken to, one of the most disliked things about contributing to clinical trials is the paper RANO forms. Finding the bit of paper, finding the scan, looking for the previous imaging, submitting it, and then someone else has to then go and find out all the relevant clinical data. Where for us, it's just here, it's online, you fulfill it, and then it's complete. And I won't show, that was a baseline assessment. I won't show the full process of a follow-on assessment, just to highlight that one of the key elements of this tool is that it shows you what the previous RANO assessor did in terms of caliper placement. So for all of the target lesions, you can see exactly where they placed the calipers on the previous imaging. That allows you to more robustly try and work out where that was. Under the older paper RANO system, it would just have some dimensions and say left frontal or some descriptor. And unless the radiologist had saved the calipers, and some systems don't even allow that, you wouldn't know what they had actually measured. And that caused a lot of inconsistency in some of the follow-ups when we were doing audits. And the other thing about this in terms of difference to the paper form is once the paper form's sent away, it's not really there and available for other people to gain access to. Having the online system gives you the opportunity to aggregate the data and then have that available to other people, both imagers and non-imagers. And if I just come out of here for a second and show you this is the kind of output that you'll see on the QMENTA system. So if you're following, so this is a newly diagnosed GBM. This is the SPPD since baseline, so the sum of the products of the perpendicular diameters. And you can see that this zone here is the zone of stability. And this patient's lesions cumulatively have become smaller. The dexamethasone dose has also reduced. They were only on 1 milligram, now on 0. And you've got an outcome here. So the current action is highlighted as continue therapy. And you can see that thumbnails are generated for each of the target lesions, showing the SPPD, the clinical status, if there's any difference in clinical status. And this gives a nice one web page summary that an oncologist or a neurosurgeon or someone who's dealing with a patient can actually show them and demonstrate the stability or otherwise of the lesion. And just as an example, here's a kind of something for progressive disease. So you can see that the lesion enlarges again, but doesn't quite make the criterion for progressive disease, but then later has progressed, and the definition here is to stop treatment. So it's a clear, unambiguous output from the RANO assessment that provided straight to the clinician, to the trial, or to the tumour board. So a bit of an update on the Matrix platform itself. So now that we've got the tool up and running, so we're approaching 400 of 1,000 plus patients recruited. 5 additional centres have joined to that existing original 10, as I said, covering more than half of the UK population. And Genomics England pathway has been adapted for what we call devolved nations in the UK. So that's Wales, Northern Ireland and Scotland, to allow that whole genome sequencing not just to be available to English patients in NHS England, but to also other patients that are participating in the platform. And there's also a suite of clinical outcome measures that go with it that are recorded separately, and it's been extended to April 2027. Its additional intervention trials have actually been set up and activated using the Brain Matrix platform. For example, the Aristocrat trial run out of Leeds in the UK, and other trials are actively in the planning stage. And we've got biomarker studies in development so that we can leverage the platform to look at additional biomarkers. And we're very much open to collaboration. This isn't a matrix presentation. This is showing how the UK is attempting to do joined up thinking and multi-centre studies, but we're open to engagement with other jurisdictions, other hospitals, other centres that are keen to collaborate. And with RANO, we're aware that RANO, albeit it's the standard, people are constantly seeking improvements to RANO or things that can complement RANO, particularly things that are bespoke to different subclasses of patient, with different prognostic markers or molecular markers. And that a lot of that stems from the fact that the enhancement that we use on the MRI to determine the lesion state is actually non-specific. It's an epiphenomenon of a disrupted blood-brain barrier. So you can see here there are 10 different things which enhance. And that is one of the reasons why people are still looking to beyond RANO. So we need RANO as the baseline, but can we supplement it or augment it in some way? And I always think of this quote from Winston Churchill when people talk to me about RANO, which, when he was talking about democracy, it's not perfect or all wise. Democracy is the worst form of government except for all the other ones that we've not tried yet. Basically saying, work with what we've got. And I hear it said, that RANO is not perfect or all wise. It is the worst form of response assessment. But I would caveat, except for all of those that haven't been validated yet, it's the industry standard. We must use it. And if anyone wants to augment it or develop on it, you must have that baseline regulatory recognised RANO assessment there to do that. You cannot just jump ahead and start proposing alterations or different approaches. So having this RANO tool available is core both to developing and delivering the trials, but also to then thinking how can we, go beyond this or supplement it. It's an established and important radiographic endpoint for the regulatory engagement in neuro-oncology and clinical trials, and any future developments will need that RANO assessment for comparison. So it has to be there. And this is one of the things that, why we were choosing QMENTA, is because in order to complement RANO, the biomarkers marketplace is a great place to start. So I'll just select some things here and go through them. So let's talk about medical imaging data. And what that does is essentially when you upload on the uploader, it uses tools within the platform to try and identify different sequences, different parameters, and classify them so that it can predefine, what is your FLAIR image? What is your T1 weighted image? Does it have contrast? Yes or no? And that is really useful in terms of checking for compliance with the sequences that need to be uploaded for trials that have very specific schedules of activity, but also for things like developing quality tools and highlighting gaps in uploaded data that help people running the trials to chase those up and look for them. And with that also comes the BIDS converter. So not only do we have DICOM imaging, but then this other metadata, the clinical data that are uploaded, QMENTA is compliant with the BIDS converter so that you can have nifty conversion that a lot of tools will use, but it's got the BIDS sidecar that has all the relevant metadata there included, so that if things are exported from the platform, you can do things like onward analysis that nifty wouldn't support, like diffusion tensor imaging if the gradient tables aren't there. And also, importantly, it has a capability for functional MRI and PET imaging. Another one that I mentioned earlier is the DICOM RT. So DICOM RT, or radiotherapy, is the DICOM extension that deals with radiotherapy planning imaging. And this is really important in particularly neuro-oncology, where people like to consider the impacts of the radiation field on patterns of recurrence, whether it is true recurrence or if it's a pseudo-phenomenon or treatment-related change. And again, just as an example, here's a case from the Matrix platform where the DICOM RT has been uploaded along with the imaging, the structural imaging that was used for radiotherapy planning. And you can see that you've got the dose map here. Also, you have the planning volumes and the organs at risk. And that's all included within that DICOM RT. And that allows both for assessment if someone wants to determine patterns of recurrence, for example, but also if you have a trial of a radiosensitizing drug. These are the kind of things where you can look at dose distribution in the brain that would not otherwise be possible. And the brain tumor segmentation tool with Editor. So this is essentially an AI-based approach that attempts to segment the imaging using existing trained algorithms, but importantly, it allows the human expert to go in and edit this and make any changes. And that's important for a couple of reasons. So here's an example, the BTS editor on a matrix case. And you can see at the moment, it's the classic enhancing tumor, necrotic core, and edema components. But you can do that also at follow-up. You can see here, surgery has been undertaken. There's the craniotomy change there. And that brings us back to this earlier. So you can see that there's a bidimensional component, but also the volume component. So with this, the volume of that is measured, and it allows you to include that in your RANO assessment. And also with that, almost as a side effect, I suppose, are the radiomics features, because once those volumes are defined and the human expert has had a chance to edit them and finalize them and submit them, you then get access to all of the standard radiomics of features that would be included in different analysis packages. Further to that, there's been a recent publication from the RANO Resect group, and RANO Resect really is looking at this prognostic impact of how much enhancing disease is left after surgery. And this is the paper here for anyone that wants to go ahead and read that. And what they've found is that there are different thresholds based on the absolute volume of residual enhancing tumour. So if you've got between 0 and 5 centimetres cubed, for example, you've got, less than or equal to 1, less than or equal to 5, greater than 5, and then you've got biopsy class, which is tissue has been sampled, but the intent wasn't to reduce the tumour volume. And the reason that's important, as you can see from these survival curves, is that the amount of residual disease has an impact on what happens to you in terms of your outcome, a significant. So this is something now that people may want to measure as part of a clinical trial. And again, that's exactly what can be achieved through this platform, because we just use the same tools. And here you can see that this is the quantification of the residual enhancing disease after surgery in this patient. Now, an important point here is the highlighting the human in the loop, because a lot of automated segmentation algorithms aren't actually optimized or don't deal well with immediate post-operative imaging, where you have blood products and air and often some post-surgical material. So having the expert have the ability to go in and edit this and make sure it's robust is really important, having the side effect that these data then can be used to go back into the loop and train algorithms so that you may have a separate optimized AI for segmenting on the post-operative imaging that allows you to be compliant with RANO Resect. And here's another example on another patient where you've got this residual enhancing component at the depth of the bed. And again, that's used to calculate. Here's the probability map for that from just showing you behind the scenes of this protocol, and really this is what you're looking at. So this is the amount of enhancing disease in milliliters or centimeters cubed. So this gives you that RANO Resect with no additional capability required. It's all baked into the platform and can complement the RANO assessment. And just to note that very recently RANO 2.0 has been released. And when we were designing this tool with QMENTA and the University of Edinburgh, we made sure that we were looking forward so that the software can be adapted easily, so that if someone wants to use mRANO, they can use that. If someone wants or desires to use RANO 2.0, it only requires minor alterations to the underlying rubric and algorithm. All of the mechanical steps are there already in the user interfaces and everything that you would need. So how do we take this? There's a data integration and there's an AI and machine learning aspect to this. And that's where the QMENTA Neuro data services can come in handy. So that's sort of tiered levels of data augmentation depending on what your needs. So we've got tier 1, which is just a bit bucket essentially. You've got the aggregated data, it's de-identified, and you can classify it and tag it. You can have the disease-specific neuroimaging components to that, which would depend on the disease, but for us, would be things perhaps like some molecular status, MGMT methylation and IDH mutation status. Tier 3 is you've got specific expert radiology assessment. So the RANO tool is one of those, or the 3D brain tumor segmentation, or an applied biomarker like the radiomics. And then tier 4 is all of that plus other things. So for example, for Matrix, we have the host and tumor whole genome sequencing available, but it would be relatively straightforward to bring in other things, from wearables, actimetry, and that really is the top tier in terms of looking at all of this data with high veracity, high volume, to try and make tools that are externally valid. And here's just an example taken from a recent paper of how that human in the loop or the oracle works for a segmentation, a semantic segmentation approach. So you've got the training sets, you've got the model, that's what's currently used. A lot of people will just predict the segmentation and stop there. That's what's going to be used for your output. Now we have the option to put it through our cohort or TESA Jewel network with expert neuroradiologists, amend it if necessary, relabel it and allow that to be put in and fine-tuned. But also importantly, the marketplace is essentially producer agnostic, the biomarker marketplace. You can come along, and as long as you can containerize your model or your preferred approach, there is this competing model zoo, and you can even set up internal competition for these to try and work out which is the best. But having that human in the loop instead of excluding the radiologists, but having it done in a very efficient way is really helpful to try and make the most of your data. So you could have, for example, an instance-aware semantic segmentation. So you'll see that RANO just clumps everything together, but often we're aware that treatment response and progression can be mixed processes, and that's ignored in current RANO things. So maybe for serial follow-up, is it the same lesion? And it's not just a numbered, discrete blobs image analysis problem where they're numbered in size, but actually it determines that, yes, this is relating to that previously, this is behaving in one way, the other one is behaving in a different way. And that kind of nuance, I think, will be really helpful to improve the quality of outcome data going into clinical trials. And also, as I mentioned, optimization of those strategies for the post-operative and post-treatment images, where there may be unexpected features like hemorrhage, swelling, post-surgical diffusion change and restriction along the resection bed, resulting in an enhancement that's not tumour-related. And this is a really useful thing, decision support tool assessment. If you want to come up with a standalone process, that's fine, you can use it. It may stand outside of the clinical radiological pathway. But in terms of a diagnostic software as a medical device class, at this point in time, it's probably more realistic and helpful to provide feedback to radiologists, and they use it and they decide what that's going to do in terms of changing their diagnosis or their certainty. So having that, the supplementation of radiogenomics or a type versus state radiomics, tumours can have the same genome but can behave very differently phenotypically depending on the environment. That allows, if you've got this setup, this process, this network of engaged neuroradiologists, we provide that ongoing feedback that actually assesses your decision support tool in situ. So let's look at some opportunities. So the main thing is we've got an immediate deployment of a centralized RANO assessment that's multi-center and multi-jurisdictional for clinical trials. So just democratizing, making it easier, reducing barriers to entry, reducing the time it takes and the workload on the radiologist to do it, and hopefully therefore getting more engagement. The platform in QMENTA is already suitable for clinical trials. It's compliant, technically, legally and regulatory. It meets all the relevant requirements. And this centralization of data allows multi-center audit of the work. We'll do scans from different sites, actually have different impacts in terms of AI tools, for example. You've now got an inclusive network of experts or oracles for rating. Rather than relying on one or two individuals at each site, you can have a dynamic group that have engaged experts, and that also allows for things like test retests or re-rating and scrutinization of ground truths, and rapid deployment and assessment of different image processing techniques. So if you want to test this, before you might have to work out a whole pathway end to end of getting the data, analyzing it, putting it back to the system, or you would have to install a local software function at every individual center. By centralizing this on the back of things like Brain Matrix, you can test that, you can apply to the study management group, say that you want to test your imaging biomarker or potential analysis approach, and it's immediately deployable, which also makes it closer to translation, because if it works in the trusted research environment, you can then test it, and it's a step closer to being delivered in the clinic. The RANO tool can also be adapted for things like RANO brain metastasis and RANO 2.0 without too much overhead. And it's a real route to collaboration. So Brain Matrix was designed to get the UK being more inclusive, not just so that you can have more patients and carers into clinical trials. So we're looking at single-digit % in the UK and high-grade glioma patients make it into a clinical trial. But it brings on board sites that wouldn't normally be equipped or able to do it because they don't have local expertise, for example. It allows investigators to join in. They perhaps will find it easier if there's a system there that deals with all the imaging and sharing rather than having to set anything up themselves. And also opens the way to interested parties. You could be an AI researcher or have nothing particularly to do with brain tumours, but you think, well, I can contact networks like the Tessagil Imaging Network or the Brain Matrix and get access to their platform and their data to outline and test some of the approaches that I think would work. So this really is about democratization of access to this and making it really easy to get your trials set up, get your trial data for regulatory purposes, but also then allow for back-end biomarker discovery. And this QMENTA, the platform so that ability to containerize your approach, put it into the marketplace, is really lowering barriers to entry and promoting that collaborative approach. So I'll finish just with a couple of summary slides now. So we've got an imaging platform now that's been used to robustly gather multi-site imaging data. It's already regulator approved. We found it really easy to whitelist across the 10 NHS sites that we're using it on at the moment, and it's very easy to get the additional 5 because of the existing trial compliance. We've got a bespoke upload form for that one-stop data capture, make it as easy as possible, no more discs, burning discs, filling in paper forms, trying to find a radiologist, trying to note the corticosteroid dose, trying to then aggregate all of that and put it through the complex, flow charts to work out what the outcome is for the clinical status. And this new online RANO tool allows that sort of secure and remote expert assessment to deliver the clinical trials rather than always relying on the same 1 or 2 individuals at your local site. And as part of that, as a radiologist, I can say that this capture of previous calipers, looking at what the previous radiologist measured, is really important for longitudinal consistency and is something that I've found always lacking from previous RANO assessments. And that reduced admin burden on the local data managers and radiologists hopefully will make them more likely to A, join up for a trial, but B, continue and have a high volume of data upload and contribution rather than just 1 or 2 cases occasionally. So we're reducing that barrier of entry to sort of site compliance and trial occlusion. And one of the things I always came across when I was doing the preliminary work for this network was that local provision of the RANO reads was always cited as a block in different radiology departments. The radiologists were just too busy, and if they weren't able to provide that locally and there was no centralised system, then the site simply couldn't join the trial, and that was therefore excluding patients that may have otherwise benefited. It also then allows this kind of re-rating of the RANO outcomes. If you want to test how robust it is or if there are any impacts on your outcomes, you can have it, say, flag 10% for re-rating, which isn't usually done in the local or distributed model. It gives a de facto opportunity for these additional metrics. So as I showed, the extent of resection or the RANO resect or any radiomics things, because of the way the platform is set up, it allows that to happen with almost no overhead. And the combination of the orthogonal genomics and clinical data with these linked databases are really useful for biomarker discovery and allowing other researchers to come in and use that. And it's deliberately modular. So there's adaptations there set in the code to allow for RANO 2.0. And also if you want to include other features that you may derive from DWI or perfusion-weighted imaging, they can then easily be combined with the existing RANO workflow to modify the RANO outcomes. And the human-in-the-loop expert rater or the oracle opportunity is really important for machine learning or AI tool assessment. Having someone there to assess the performance, generate new ground truths on the fly related to your actual data, not some other unrelated training data set. That's really important, and it's dynamic. The data accrue as the study continues. And perhaps a really crucial thing just to remind is, for all the additional potential here, fundamentally, we need RANO to deliver on the clinical trials, but also if you want to develop or move on from RANO, you need that basis if you want to determine non-inferiority or superiority for comparison and validation studies if you've got a development of RANO or a novel biomarker. And that's a really key thing. This RANO tool opens the door to both clinical trial delivery, but also how do we move on from this? How do we test if RANO is appropriate in certain subgroups with different molecular characteristics? How do we then determine whether a modification to RANO is acceptable or successful? And just here's some of the references for the papers that I didn't include the screen grabs from, and just to highlight again the role that QMENTA and Edinburgh University has played in this, alongside the brain tumour charity in funding the Tesogel brain matrix. And I'll leave that there for any sort of questions, discussions.
This is just fantastic. Great work. I see that there is some questions coming. The first one from John Air is the RANO tool only for use in brain metrics?
Yeah, it's a great question, actually, and really important to highlight that well, the RANO tool was developed as part of the matrix approach and the democratization of access to trials. It's not locked to brain matrix. It's designed that can be used by anyone in a kind of imaging CRO capacity to, if they wish QMENTA to provide that for their own trial.
I have another question from Christian, which is how easy is to set up a project? And can you tell us something about the roles assessment?
Yeah, so the setting up a project is very, very simple. The guys from QMENTA will handle all of the selection of servers and the data that would be used to store your data. If there's an existing upload platform that you want to use, you can select that. We were able to generate a bespoke one that just had the fields that we were interested in for a particular metadata. And once it's up and running, it's browser-based essentially. So I was doing onboarding with each individual site, making sure they had test data available and showing each individual data uploader how to do it and go through the processes. And then they have control. So the roles are quite important. So a data contributor role, they can see all of the imaging data that they've uploaded from their own site. They can deal with that. They can check. There's a viewer online that if they think they may have, say, uploaded the wrong patient, for example, they can check and compare that to the imaging that they have. And is it correct? And there's audit there. They can also then download. So if I perform a segmentation on one of their patients as an expert, they actually have the ability to take that segmentation and download it for themselves, separate from releasing the data as a whole package. The other user types are the administrators, who obviously have a bit more. They can add and delete things that other people wouldn't necessarily be able to do, although it's all audited as part of clinical trial conformity. And then the third class is the rater class, or the radiologist class. So those are people that get the work list when if someone uploads a new image for a patient, then appears as on a work list, and I can log in, or a colleague perform the assessment and complete it. Also for the segmentations, so we have the ability to edit that, and it's not locked by location. So in theory, as long as it's regulatorily allowed, someone from another country or another jurisdiction who's a vetted expert and allowed to do it could log in and provide those assessments also.
Okay, we have another one that is, what is your experience with AIDS of onboarding of new sites and users of the platform, and specifically the RANO tool? How fast can someone new start doing assessments, I guess, without your support?
So in terms of the RANO tool itself, it is not particularly different from the standard way of doing it, which is me as a radiologist. I get a list emailed to me from the trial coordinator in my hospital. And this is the painful bit, I have to go and find the bits of paper for the trial, find the workstation, and then log in, find the patient, decode their identities, do all of this, and then provide that. And then I need to send those bits of paper back to someone else, who then fills in other details, and then that's sent to someone else who manually types it into like an ECRF or a web form, and then it gets sent away. What the actual mechanics of sitting, measuring the tumor, checking that it is the correct data and all of that, the online tool actually makes it easier. So there is a bit, it's helpful if I go through it with someone and just explain the order in which it does things, and how, for example, you can re-window or change the orientation of a 3D image in the viewer. But that is all easy for any radiologist to do. I know every neuroradiologist I've shown it to, without exception, has preferred it far more to the standard way of doing it with packs and paper. And the biggest challenge is actually on onboarding is that, and this is just something to be aware of or admit for any site, the RANO tool itself is straightforward. in the UK, different neuroscience centres operate with their cancer centres in different ways. So some of them, everyone gets scanned in the same hospital. For others, they get their surgery and radiotherapy in one hospital, but then they may be followed up in a district hospital elsewhere. So actually, a lot of the onboarding is nothing to do with the RANO tool itself. It's me helping troubleshoot sites to aggregate their data. And that's important as well, because in some of the sites, they've previously not contributed to trials that require RANO assessments for two reasons. One is they found it difficult to aggregate data, and two is they couldn't find a local radiologist to perform the reads. And this tool gets round both of those basically by providing solutions to during the onboarding process. But any radiologist can do the RANO assessment, and I have time myself doing them. It literally takes me under a minute to do one assessment. It's, you know, because I just log in and do it. I don't have to find bits of paper, send them, check emails, or anything like that. It's just log in, perform it, and then log out again.
Yeah. Okay, great. I think that's great, because I don't see that many other questions coming, and I have actually one for you, Doctor, is how would you normally, for I guess maybe everyone here knows the answer of these questions, or most of the people, but how will you normally perform this RANO assessment without the technology that we have nowadays?
So it was literally just measuring the on a pack system, applying the calipers and measuring it. But in addition to what I've already described in terms of the, you know, finding the paper forms, filling them in, sending them back, a lot of the PACS system caliper tools don't force it to be perpendicular. So you actually get some noise or inconsistency in your RANO measurements, because when you draw the first caliper and then you draw the second one, if it's not entirely perpendicular, then that's a source of error or uncertainty. Whereas this online tool, you cannot alter the angle of that. It must be perpendicular. Also, from a centralized trial, once that RANO assessment is sent into the main unit, they have to trust that the radiologist did the right thing. And the second radiologist, let's say it's a different radiologist, performs the next imaging visit, they can't see what the previous radiologist did. And that creates an awful lot of uncertainty and jitter and noise in this thing that then cannot be assessed, because it's not part of the trial documentation that you can go back and assess independently the performance of the radiologist. Having the online tool audits all of that. It saves every caliper. It's there in perpetuity. People can go back and look and decide if someone's, you know, let's say it looks like they've done really well and then they progress, is that a function of the drug, or is it some sort of unusual way that it's been assessed? You can go back and assess that now, whereas before you couldn't. And also, with everything stuck in the hospital on the PAC system and then recorded on a piece of paper, there was zero opportunity for you know, say automated segmentation for volume tracking or radiomic generation. So by having it online and having it backed up by the biomarker marketplace, not only is the process of doing RANO much easier, all of that additional capability becomes open at the other end, which you just wouldn't be able to do without very difficult federation techniques, which can be difficult to set up and assess.
Great. Well, thank you, Doctor. I think I don't know if you would like to add something from the presentation, or something, any phrase to wrap up this webinar.
Well, I'd just like to say thanks to everyone who's tuned in. Good morning, good afternoon, or good evening, wherever you are now, or where you are if you review this later. And please don't hesitate to contact myself or QMENTA if you want to find out more about this, and particularly if you want to collaborate and you've got a tool or a biomarker or an idea for something for clinical trials in brain tumours, we'd be more than happy to discuss that and take that further.
Okay. Yeah. Well, thank you so much, Dr. Gerry and Thompson. It's been really enlightening. Also, I can speak for myself that I work in the industry, but don't have always the opportunity to listen the input from someone that is actually working in the field and facing all these problems and find innovative solutions for this matter. So thank you so much.